Hi, good afternoon, everyone. Today is August 10th, and this starts our Unit 5 discussion. Today we're going to be talking about lasers and different types of lasers, ESU, etc. So there's a lot of things uh, that are very important in this chapter that pertain to your job and keeping patients safe. So our objectives for this unit, we're going to describe what those are, electrocautery, lasers, and how it does correlate to fire safety in the operating room. So our assignments for this week, your discussion was actually due, your first post was due yesterday, Wednesday, but you still have to respond to one peer by Sunday, so make sure you're getting that in. I still see a lot of you getting points taken off for that because you don't go back and respond to a peer. So please make sure you're doing that for full credit. You got this research paper here for about fire safety, which we're going to talk a little bit about today. So hopefully that will help you with that. All right, so let's start off with a question here. Did you know that approximately 85% of operating room fires occur near the head and neck? A lot of people don't realize how much of a risk there is for a fire in the operating room. I don't think a lot of patients really consider that when they go in for surgery. And I think if they did realize how high that fire risk is, they may reconsider. You know, when we're giving them, or the surgeon is giving them, all the pros and cons, sometimes I think they may leave this one out. That's just my personal opinion. But anything near the head and neck, because of the high oxygen concentration, puts that at a higher risk for fire. So we are going to talk about different types of fire safety, what could cause fires, because we're going to be talking about the electrical portion of it today. So the first part we're going to talk about is the electrosurgical unit. Sometimes we just call this the ESU, which is what it stands for. Sometimes we just call it a Bovie or Bovie pencil. It is also considered the active electrode because it is doing the active portion of this electrical current. So it does use an electric current that comes from the machine, the ESU unit or machine, that this handpiece or pencil gets hooked into. So it does come sterile. This will be a sterile item on your field. And you'll take about half of the cord and toss the other half off to your circulator. And the circulator will plug in the three-pronged part into your unit. So the white handpiece stays on the field for your surgeon to use. So just a little bit of a background. It was created in the 1920s by someone named William T. Bovie, and he worked very closely with Dr. Harvey Cushing. You will probably hear the name Cushing quite a bit as well. He was a pretty famous surgeon, neurosurgeon. So a lot of instruments are named Cushing after Dr. Cushing here. So they created this machine that uses an electrical current, and they realized how beneficial it would be to use in surgery to cauterize tissue. So this word cauterize means to burn tissue by using electrical current, or you could use chemicals in a different sense, okay? But don't confuse it with this term, coagulate. Coagulate means to clot blood, which could be done chemically as well, but not typically electrosurgically. So don't get these two terms confused. I've had students in the past get them confused, probably just because they start with the C and it can be kind of similar and confusing. So I just wanted to point that out to you. So the whole point of this handpiece, you notice it has two buttons. If you were to look very closely, one would say cut, and the other one might say coag or cauterize. But we are really referring to it in the cauterized sense here. All right, so it hooks up to the machine, generates the current. That current is going to come through the cord, down the handpiece, into the tip. Okay. So along with the ESU, we also have to talk about another portion of it, not just the handpiece, but we call it a Bovie pad or inactive electrode. So remember the pencil, the handpiece part was the active electrode. The pad that goes on the patient, grounding pad, or the patient return electrode is inactive. It is also important to note this is not sterile. This is not a sterile item. It should never be on your surgical field. It is going to be placed on the patient, kind of see a picture right here, prior to the start of surgery. That way your circulator doesn't have to crawl under the drapes and place it later. But it is sticky on one part, and this cord plugs into the machine that I'm going to show you here in a minute. It only goes one way, but anytime you're using that Bovie pencil, you have to have this grounding pad. And really the machine is set up in a way that if you tried to use the pencil without the pad, it would set off an alarm and wouldn't let you, which is a good thing. Because if you were to use the pencil without having this grounding pad on the patient, you would burn the patient. You would electrocute them, essentially, is what would happen. So you don't want to do that. So the machine does have like that fail-safe set in place that, it shouldn't do that without having the grounding pad in place and plugged in correctly. And it will sense if that grounding pad, even though if it's plugged in, it may not be, on that patient completely. It may not be in full contact with the skin or something. It would sense that. It wouldn't let you do the thing. So the whole point of this grounding pad is to return the electrical current to the machine. Now, I'm not going to get into great detail about how electric current works. The thing you need to remember is that this is going to be what's called a closed circuit, in that we're sending an electric current from the machine through the handpiece. And if we activate it on tissue, it's going to go through the patient, then return through this grounding pad back to the machine. So it makes one complete closed loop. That way it doesn't just continually shock the patient. So that's important to remember. When we're placing this Bovie pad, you have to put it on an area with a larger muscle mass, or like a meaty area of the body. So this little picture here shows you could be, most often I'd say we probably do lateral thigh. You could do it on a flank, as long as they're not super skinny. Maybe even the buttocks region, upper arm. I've even seen it on the calf if necessary. So it kind of depends on where you're working. If we're working in the abdomen, a lot of times the thigh works really well. If you happen to notice, if you're maybe the one in the room putting this on, you're not sterile, that there is a big long incision over, let's say, this patient's right thigh, and that's where you want to put that Bovie pad. You see that big long incision? You're going to want to ask your circulator, does this patient have any metal implants? Because it'll cause a reaction. Metal is very conductive, so we don't want to put that grounding pad, send that electrical current over that metal. It'll just burn the patient. So always make note of any type of incision in the patient that could indicate that they have an implant there that they may have forgotten to tell the patient. I've seen that a lot, where maybe especially elderly patients forget that they had an implant from maybe 10, 15 years ago, but the scar is still there. So make note of those things. You could use the other thigh if necessary. We used to say to avoid areas that had tattoos. You wouldn't want to put it over that, because back in the day, a lot of tattoos contained metal. I think they've really gotten away from doing that. So I think anymore, it's probably okay, unless it looks like a really old, maybe even prison tattoo, you would want to avoid those areas. Also, if this patient is very hairy, you may have to use a hair clipper to trim that hair back to make a spot for that to stick. You could, you might even have to use two pads, like take one off, the hair off, and put another one on if necessary. And also make sure the patient isn't sweaty. You might have to get a towel or something so that it's not moist. So a couple things to remember when placing grounding pads. So here's what the machine itself looks like. Sometimes you'll see it on like rolling cart, depending on your facility. You might have it like permanently placed in the room on like a type of shelf, or we call it a boom. Boom hangs from the ceiling, and it can move around the room. So that's where a lot of ours are located, but it could be portable. It's always going to contain this main portion that has the plugins for the hand pieces. Now, this one I didn't get a picture of and I should have, but I didn't get a picture of it on this slideshow, but there's another one called a bipolar that does not require a grounding pad. And it looks like a forceps. It has two sides. So the current is actually contained in the tip of the bipolar. You can kind of see a picture of it here. So the current goes down one side of the handpiece across and down back the other to the machine. So you don't have to get a grounding pad for a bipolar. Bipolar could be used for a little bit more precise cauterization. It wouldn't be used for cutting tissue, but a little bit more precise cauterization. So you'd have the place to put the grounding pad. It says to the patient, accessory. You could have another one here. But it's going to have somewhere in the middle. This one has a couple because you could hook up more than one, but a place to adjust basically the intensity. So a lot of doctors have a preference on what they want their cut and coag to be. So you're gonna, adjust this prior to the case, or you could increase it during the case if necessary. If it's not getting through the tissue, if it's not cutting through the tissue well enough, your circulator can come over here and bump this up. You can also adjust, at least not on this one, but you can also adjust how the electric current comes out the tip. Oh, you can't hear, I see it. Blend, pulse. There's a couple ways that the current actually comes out of the tip that changes how it cauterizes tissue. So I just wanted to show you, a lot of them also come with foot pedals. So you can have a different type of handpiece that the surgeon would just press on the pedals. We use these a lot in like cystoscopy procedures, etc., ENT. So the different handpieces would hook up to it, but they could use their feet to activate it. So I kind of already touched on this, but this is a good visual of how the actual unit works. So that was what we just saw here, this picture of the machine. That's where the current is generated from. It's going to go through the handpiece cable, the active cable, into your Bovie handpiece, or the active electrodes, the other term for that, into the patient's tissue. Then that current is going to come back out of the patient's tissue to that return electrode, which sends the electrical current back to the machine. So you can see better in this picture how it's a closed loop, or like a complete cycle for the electrical current. So a couple more considerations when you're using a Bovie pencil in order to prevent fires. So you want to keep this Bovie pencil in the holster that it comes in. It's like usually a white plastic holster. It could be blue, whatever. Keep it in this holster when not in use. So every time that surgeon lays it down, they're done with it, you make sure it gets put in that holster, okay? Because what can happen is if the surgeon leaves it laying up on top of the patient, maybe they're trying to like see and they accidentally lay their arm down on it, or somebody else lays their arm on it and activates one of those buttons while it's sitting on the drape, those drapes will go up in flames pretty quickly. It'll burn a hole right through that drape and then could burn a hole right into the patient. So be very careful of that. It could set the whole drape on fire. I've seen it burn a hole in a drape before. So definitely be mindful of that. Some surgeons are a little more stubborn and don't like it in the holster because I don't know why, they're just stubborn. I think it's easier just to pick it up off the patient. Laziness is really what it is, but you are still responsible for that. You also want to keep the tip of the Bovie clean. Most Bovie tips now are what we call coated, in that you could really just use maybe a towel or a lap tape and wipe the tip of it off, and keep all that built up tissue, that burnt tissue on the end of that Bovie. It's called eschar, E-S-C-H-A-R, eschar, is burnt tissue on the end of that Bovie. But if you leave it built up on that, it's A, not going to be effective, and B, could spread the electric current in a way that is not intended, which could lead to a fire. So you also want to keep those Bovie settings as low as possible, but still remain effective. You don't want to jack it way up. That's really increasing the amount of electric current behind it that may not be necessary. Also, you don't want to be using the Bovie if you've just poured, like if you're irrigating the abdomen with saline. and the surgeon sees a bleeder and wants to bleed right, or cauterize right into that. Saline is conductive. It will carry an electric current and burn everything in that's touching that saline. So you cannot use the Bobby in the presence of saline. That is one of the conductive types of fluids. There are several other non-conductive fluids. If you're going to be doing a lot of cauterization while still in a fluid, you'll have to pick a different one, like glycine. I don't know, there's a lot of other options for different like endoscopy cases, going in with scopes that you could use. You're going to keep saline on your field at all times. I've seen a lot of surge techs who have gotten lazy and they're like, no, I don't need any right now. Just wait and see if I need any. But what could happen is you have this, potential fire starter on your field. What if something does happen and you need something to throw on that fire very quickly before your circulator can run and get an extinguisher or the saline? You have to have something on your field that could potentially put that fire out quickly. So I always kept saline on my field all the time for that reason. So to touch on this, because it kind of goes with everything of the fire triangle, we have talked about some of the fuel. We've talked about the drapes on the patient. Alcohol skin preps, especially anything alcohol based, is very flammable. Even the patient's own hair can catch on fire. The ET tube, like I said, with airway fires, very dangerous. So the fire triangle has 3 parts to it: an ignition source, like our ESU or lasers, the fuel, and then an oxidizer like oxygen or nitrous. So the idea here is if you were to remove, one of these, it's going to collapse the triangle and you're not going to have enough for a fire. So you're trying to eliminate something in this fire triangle as best as possible. Now, sometimes we can't get away from using electrocautery for the type of surgery or a laser. Sometimes it just can't happen. But what we could maybe minimize are the fuels or reduce the amount of oxygen in the area. So consider these types of things for every single case, right? Not just airway fires, every case. All right, so let's move on to lasers. A lot of people don't know this, but laser is actually an acronym. You should know what this means. It stands for light amplification of the simulated emission of radiation, because that's what's actually happening. It's about light. That's how lasers work. Okay, so it's based on, it says an intense controlled beam of light based on its light wavelength. So all the different types of lasers have a different type of wavelength. We're not going to get into too much detail there, but lasers can be very effective for a lot of different things, a lot of different tissue. Some lasers are absorbed in dark tissue and some are absorbed in clear tissue. So it really just kind of depends on what you're trying to do to pick the correct laser for the job. But it is very precise. I mean, this tip right here, that's what a laser looks like. Very small, very precise, and really doesn't spread any electric current outward. So you don't typically have to worry about surrounding tissue damage. So you could see these in a wide variety of cases. We could remove certain types of tumors or cauterize. A lot of plastic surgery, any more skin level type of plastic surgery, are done with lasers, eye surgeries, etc. So actually here are a few examples of some of these lasers. These are some of the most common, especially CO2. We use that one a lot. You'll see in general surgery, OB, removal of condylomas. It's a genital wart, so it's very effective in doing that. Argon, this is ND-YAG, and holmium-YAG, dye and excimer. So I would just kind of familiarize yourself with where you might see these, especially holmium-YAG is used a lot in urology, taking out stones. So it depends on what you get into. Actually, here is a video. This is called a laser lithotripsy. So lithotripsy means, tripsy is like to break apart. Litho is stone. So in this case, it's like a stone in the ureter or even all the way up into the kidney. So it's going to demonstrate how they can use lasers to break up these stones. that gives you a little bit of an idea of how that works. You know, it when you're watching it on the screen when you're in the surgery, to me it kind of reminds me of something you'd see out of like Star Wars because it even kind of makes the little like sound. It's really kind of bizarre, but they're pretty cool to watch to see, you know, a laser break up a stone, and then you could use baskets, like it said, to like capture the pieces and pull those out because these stones were too big for that patient to pass. So it's pretty cool. So real quick here at the end, laser safety guidelines, kind of like going back to the fire triangle, you know, there in the Bovie guidelines, there are certain things that you can do to prevent those fires when you're using lasers. So, and things to protect yourself, like this one, eye protection. This isn't something you have to do with a Bovie, but if you're using a laser, you know, and maybe, and I didn't actually put it on here, I meant to, under general, you're going to also use types of instruments that don't reflect light or laser. So you wouldn't want to use your typical shiny silver looking or stainless steel instruments because it could reflect that laser beam. So you're going to use like a black matted, non-reflective type of instrument. But, you know, if you didn't and you had that laser beam bounce off something and into your eye, you know, that laser beam could be damaging your retina, your cornea, whatever. So we have to use the correct eyewear for the specific laser type. So you'll see different laser colored glasses, and it depends on the laser you're using. Sometimes the laser glasses are orange, maybe they're like a dark brown, green, sometimes they're clear, and it depends on the type of laser you are using. So, and it has to go all the way around. The entire eye has to protect all visual sides, all visual fields, just in case it came at a weird angle. So typical glasses like I'm wearing now wouldn't be acceptable, wouldn't stop a laser beam. So it has to have that tint, the correct tint to it. Some fire safety things, always use non-flammable prep solutions when you're using a laser. So like your things like chloroprep are alcohol-based. You wouldn't want to be using those. You're going to have a higher fire risk for that. You also want to let any, even if it's not alcohol-based, any prep solution to fully dry. You don't want it to pool, like, you know, keep a pool of it in maybe the patient's belly button or on their sides. Allow it to fully dry completely. Now, if we are working in the airway with a laser or a Bovie, they're going to use a special fire retardant ET tube, endotracheal tube, because if, you know, the oxygen-rich environment coupled with maybe a drape near the face and a Bovie or laser, you know, you've got your fire triangle right there. The fire, if it starts out here, could actually go into the patient's, through the patient's ET tube and into their lungs and burn the patient from basically the inside out. And it's happened. And it's really detrimental. And usually the patients don't make it. So airway fires are very scary. You also want to use, or anesthesia will use the correct gas composition. So they may mix nitrogen with oxygen to make it a little less flammable and still keep a good oxygen content for the patient. So with laser specific cases, you also want to restrict traffic flow into the room. You don't want a bunch of people coming in and out because, you know, they may not have their eyewear on, or they're going to be at risk for accidental laser beams or whatever. So restrict traffic. You're going to put warning signs on any entry into that OR that a laser is in use. On all the doors. You also, right along that laser safety sign, put a extra 1 or 2 extra pairs of the correct laser glasses on the door. And again, you're also going to want spare water or saline on the field to put out any potential fire, but you're also going to use wet towels around the laser site completely. So that would dampen any of those drapes that might be, you know, exposed. Okay, so I know that's kind of a lot to take in, but they're all very important topics to help, you know, keep our patients safe with fire safety pertaining to ESU and lasers. So hopefully you got something out of this. If you have any questions about any of this, please reach out. My email is mludwig@herzing.edu. I do have office hours on Tuesdays. If that doesn't work for you, just send me an email or, you know, get in touch. We can try to work something out. So hope you guys have a good rest of the week. Bye.